Okay.
This event is being live streamed. Cool. Fantastic.
Has he got 56? I'm assuming it's working. Great, it's working.
Cool. Fantastic. Just minimize that.
People are still joining, so let's give the 30 seconds.
Yeah, fine. Well, I'll just treat myself to a delicious fisherman's friend in the meantime.
Cool. Should we start?
Yeah, sure. All right, well, I hope you can all hear us. As you probably all know at this point, we're going to give a talk this evening about the Specialised Foundation Programme, the academic interview. Welcome back. My name is Daniel Richardson. I'm an academic clinical neuroscience foundation doctor at King's College Hospital, and I'll let Jack introduce himself.
I am Jack, as per last week. I'm an AFP in critical care at Barton Health, North London.
Cool. So, very similar format to last time. We're going to talk a bit about the academic station generally and the sort of things you need to expect and prepare for. Then we're going to focus on critical appraisal for probably the mainstay of the talk. And that's probably the bit that most people, I think, find intimidating and difficult to prepare for. And then at the end, time dependent, we will answer any questions you might have if we've not answered them already.
Yeah, but pop them in the chat and I'll be manning the chat throughout if you do have questions.
So really brief disclaimer. So all information is based on our experience and it's been information passed down from people to us, which we're now passing to you. We're not endorsed, we're not attached in any way to the foundation programme or to any specific university or deanery. And pretty much everything we're talking about is freely available in public domain. We're not giving any, super sneaky insider tips or anything like that, that would give people an unfair advantage. So just to recap really quickly, so the whole interview starts with 15 minutes preparation time to cover the clinical station, which we talked about last week, and the academic station. You can decide yourselves how you want to split those times for preparation. There's a time gap for an unknown duration, which I think for Jack was mere minutes and for me was about 2.5 hours. And I've heard shorter and I've heard longer. And then really the academic station is around personal questions about your motivations for the Specialised Foundation Programme, and then looking through an abstract. And then the clinical station, as we've covered that last week. And the recording is on the medal site. We're not going to touch that at all this week. The panel is made of an academic lead, clinical lead, and an additional observer. And we can talk a bit more about them in a bit. Anything to add there, Jack?
No, covered it all, mate.
All the same as last week, which is nice and easy. So top tips, again, to prep time, just to reiterate these things. So you do read through the abstract as a whole first before you even start kind of making notes. Try and get your head around what you're going to be asked to present. make brief notes on key components and discussion points. Don't try and copy it all out verbatim. You will run out of time. It's a really bad use of your time to try and do that. Do definitely use a structure. Obviously, you can only bring a blank piece of paper to the interview, but once the prep time started, no one can stop you from copying out a structure verbatim and then using that to formulate how you take the notes of your abstract. And then, as I've already mentioned, be prepared to wait. And if you do wait, obviously make sure to use that to your advantage. I've already said not to try and copy it all out. If you feel like you've finished preparing before the time finishes, then don't feel that that's a bad thing in itself, and don't necessarily allocate 50-50 between the clinical stage and the abstract. And then something that I'm not sure everyone knows, but just so you are clear, you don't have access to the abstract as you present it. So all the notes you take are all the notes you'll have, which means if you don't write down specific things, unless you're very good at remembering, you're going to really struggle to talk about specific things. Cool. So to talk more specifically about the academic station, it's 10 minutes long. And really, you should think about this as it's your opportunity to demonstrate why you stand out as a candidate, why you deserve a specialized foundation program job, and what unique experiences and skills that you have essentially make you the ideal candidate. Why should we give you this job as opposed to everyone else who's applying? There's probably quite a bit of discussion around your motivations and research background. You will be expected to present and critique an abstract, and expect to answer specific questions about data to give definition as well. And we've already said it once, we'll say it again, you definitely don't have access to the abstract as you present it. Cool.
Very good, yeah. I suppose the only thing I'd add to what you're saying is with this abstract and not having the information throughout, certainly beneficial to practice writing in a specific template, because it's going to move so fast that you really should practice where you're going to guide your eyes when you flick through and flick down. So I'd actually write everything in exactly the same format, irrespective of abstract, on a piece of paper, because these interviews move so quickly. And it's really hard to retain that amount of information, and especially thinking about what Dan experienced. Imagine reading an abstract and then having to wait 2 hours before your interview. It's going to be really difficult to retain that level of information. So really practice your prompts and stuff. I suppose that's all I'd have to add there.
So I suppose talking about, parking the critical appraisal in the abstract for a second, that's, one part, and that's difficult. But the other thing that I think is really important to think about how you can capitalize on is the discussion of your motivations and the reason you want an SFP. So you definitely should be practicing, if you've not started already, going through basic interview questions that are likely to come up, not just here, but every interview for pretty much the rest of your life. So things like, tell us about yourself. Why would you be a good candidate for this job? Tell us a bit about your background. You want to be able to give, not rehearsed sounding, but honest, candid, smooth, and kind of well-rounded answers. The way that I practice this, and I think Jack probably did similarly, is talk to yourself, present these answers to yourself in front of a mirror or using your phone, and then just watch it back. But essentially, you need to get really good at saying answers without saying and and adding all these extra bits in, because each one of those things is just a couple of seconds. And in 10 minutes where there's so much to cover, if you spend half the time thinking about how to construct your answer, you'll lose out on valuable time that other candidates will spend showing why they're such good candidates. Anything else you would add, Jack?
I think the difficulty in the personal questions is timing, because you have 10 minutes both for personal questions and abstract interpretation. When you try and talk about all of these 4 things that Dan's kindly listed here within essentially what should be no more than 2 minutes, it's really hard. So I fumbled this part of my interview, and I think even though I practiced a lot, I simply didn't practice enough. especially considering the nerves that you'll be experiencing during your interview. So I'd be really strict on your own timings at home.
Yeah, and you'll be surprised if you write out some bullet points and try and present an answer. What you think would only take 30 seconds to say will fill 3 minutes, and that's more time than you have to talk through. So it's definitely worth practicing.
I've got a question here that's actually prompted another thought, which is, what does it mean, the last point regarding London? So in the London deaneries, you'll be interviewed by interviewers that have no idea about the preferences you've selected and whether you've selected one single job or 30 jobs. Our advice would be, you may be asked a question regarding why do you want this SFP, and it's going to do you more favours, again, personal opinion, not published anywhere, to have well researched and understood a single job and demonstrate that you are the perfect candidate for that one job, rather than approach the question as if, oh, to be honest, I don't mind which London job I get. I think the former is better, and they'll have no idea about how many jobs you've applied for or which job. That's what we mean by the final point.
Yeah, I mean, I don't know who interviewed you, Jack, but I had an orthopedic surgeon and a neonatal specialist, and I was applying for clinical neuroscience jobs. So,
yeah,
you know, they weren't interested in things I was interested in, and I wasn't necessarily things, and none of you know what your motivation for going there is. So I think making it really clear as a candidate that you've researched a job, you know exactly where you're applying to, and you know what you want. And that's much easier to practice for as well, giving an answer like that, as opposed to trying to show that you're really passionate about something, but also keeping it very open and generic. That's going to be much harder than just saying, I really want this one job. Just give me this one job, and these are the 8 or 9 reasons why I'd be perfect for it.
Yeah, but similarly, there really is no excuse for not having any idea about your first choice job. And I don't know what Dan did, but I certainly bugged a lot of people doing the job currently is a pretty good way about finding out about it before. If not, some employers are much better at publishing online than others. So have a good dig around the internet.
So for people interviewing outside of London, a bit of other kind of advice that changes things slightly, I suppose. So I interviewed in Cambridge, and I found it was more conversational. It was less like me presenting something at someone and someone just silently marking me and asking questions. It was far more conversational, but I was also pressed much more on my points. So I felt that in London, I could say things and they would go completely unchallenged and they would just be accepted and okay, yeah, that's fine. Whereas I certainly found that there was more scrutiny given to my answers, and I was asked to defend things a lot more. The other thing to think about if you're applying outside of London is that you might not necessarily be given an abstract. For Cambridge, this is definitely true, and I think the same is true of Oxford. So you're more likely to expect a question like, tell me about a piece of research you've read recently. And if you're applying for an academic job and you can't present one bit of research that you've read or heard about recently that you can roughly talk about, that's going to really kill you off an interview and be really awkward. So think about definitely having 1 or 2 papers that you've read through and that you could talk about the implications of, or why you think they're interesting.
I think you told me, didn't you, mate, that you were asked, or someone was asked, you went to present a paper and they immediately interrupted you and said, no, not that one. Yeah. So I think that's quite a common, or it's certainly something I've heard, is that, you know, if you present one paper, they'll ask you, no, I've already heard about that, give me another one. So have one you're really confident, but definitely, you know, if you've got 1 or 2 in your back pocket as well, that's, you know, the sort of thing that will save you from having a bit of an awkward moment, a nightmare in the interview. Expect more questions about yourself. And also, I think importantly, expect to be interviewed by someone who's an expert in the field. So I applied for clinical neuroscience jobs and I was interviewed by a professor of neurocritical care, which meant that things that maybe other consultants or specialists would not know anything about and go, okay, yeah, that's a reasonable answer. I was really pressed on. So I suppose make sure you know your own research. And if you're going to talk about research, make sure you know what you're talking about and you're not going to try and pull the wool over someone's eyes, because you probably will get caught out.
But that's probably the most advice I could give outside of London. But happy to answer any questions if people have got some. I can talk about that later. Let's move on. So that's general interview advice. And then I guess moving on to critical appraisal, which is the bit that I think everyone finds intimidating. So essentially, it's a short structured summary of the abstract you've read, but that's, I think, where people think the focus should be, but actually that's missing the point. What you really are being asked to do is give an appraisal of what you think of this paper. Do you think it's a strong paper? Do you think it's a weak paper? Where does this sit in the literature? You know, what's the context of the paper? Your overall interpretation and kind of clinical relevance. And you really should be aiming to do this in about 5 minutes or less, because actually you're going to ask them, you're going to have questions beforehand and questions afterwards. And if you fill your entire 10 minutes talking about this abstract, you're not going to be able to maximize the other points that are available if you're just talking through your abstract. I would say the key to this, and we'll talk about this a bit more, but the key is giving yourself structure and signposting the person who's interviewing you where you're about to go and what you're going to talk about next. Because actually they have a tick form, they have a mark sheet, and if you're just talking and run-on sentences, it's really unclear where you're going to go, and they might miss some of the really good points you're making. Whereas if you label your points and you make sure it's clear before you start talking about them in detail, people will be able to follow you much more easily. You should expect to be interrupted. And when you're practicing with other people who are applying, interrupt each other and see how easy it is to knock someone off their flow. Expect to have to defend or justify your interpretations of data or how you explain it. Expect to be asked to kind of reword your argument of, okay, I didn't really understand you, but can you just say that again in a different way? And I think those were experiences that we both had at interview.
Yeah, I was certainly interrupted fairly early on to defend a point. And I think this can throw people off. It doesn't necessarily mean that the point or justification you've made is wrong. It's testing your ability to communicate and justify your arguments. So that felt like a very key point of the interview. And a focus of my practice, don't know whether it worked or not, was to really think about how I describe certain aspects of a clinical trial or points I was making, because you may be asked to justify them and it's really easy to trip up on your own words. So that would be my experience on that.
Oh, that's weird. Oh, I done that. Sorry. There we go. Right. So having talked about structure, I think the most common structure that we both used is the PICO structure. And that's probably what most people have heard of. If you have a different structure they're already using, you're comfortable with that, then stick to that. I think we're pretty close to interviews for some people. They're in the next 2 weeks or so. If you already have a structure, don't swap to this one in the last 2 weeks. It's a bad idea. And if you don't have a structure already, then pick a structure and start using it. So to talk through the critical appraisal, I suppose, Jack, how would you go through it? What would you say is how have you gone through them?
How have I gone through what the abstracts I've been given?
Yeah, when you present the critical appraisal.
So I've always presented a line or two summarizing the abstract, literally a sentence or two, describing the key structure and any important findings or conclusions that the authors have made. And then I will, for each of the PICO, try and aim for 1 or 2 key points. I think it's really easy for people to get caught up in the minutiae, or perhaps if you have, for example, a statistical background, to spend all of your time speaking about the statistics of the study itself. And I really, personal experience, don't feel like that's the point of these interviews. So would be focus on 1 or 2 key aspects. I think you get no points for reinventing the wheel. The interviewers will expect a PICO format, and it will actually be very easy for them to follow if you just follow that format and talk within it. So I mean, mine was very simple. That's how I did. But I approached this as likely getting the academic part of the interview first, likely being extremely nervous about my interview. I was just trying to make it as simple as possible for myself. And I feel like it went reasonably with that approach. I don't know, did you take the same route, Dan?
Yeah, I think so. I think as you said, actually, people get really caught up in the minutiae sometimes, especially around statistics and trying to kind of explain a really difficult point. But actually, if you think about how much you need to do in 10 minutes, I would stick to making big, simple, easy to argue points that are going to be easy to defend, easy to understand to the person you're making them to, and that makes sense. I think going off and kind of having to set the scene and say, well, actually in statistics, blah, blah, blah. By the time you've made the point, you've used all your time up and you might not have actually necessarily made a particularly good point. So very similar to you, I gave a very brief summary of the abstract. Then I review the abstract in the same format that I've reviewed it. So, population and intervention, then comparison, then outcome. Talk about any other valid points. And then I think also importantly, although we're interested in research, it's a clinical kind of position, right? Like we do research, but not pure research. So I think every paper is worth drawing it back to how would this change clinical practice? What's the relevance to people's care? And I think that's a nice way to finish your summary and to bring it back and then, open up for discussion and questions about the points you maybe have made. So it sounds like we both did a very similar thing.
Yeah, I mean, I literally, in my preparation of writing down as well, every single abstract we did through preparation, I'd write a 2-line summary verbatim, because I knew that would be the first thing I'd be asked, and I'd have time to practice that whilst waiting. And then I'd write in big letters PICO and 2 key points for each. And if I had still more time, I just put down minor points around the outside. And actually, you'll find when you're practicing that irrespective of abstract, you'll just soon fit into a format that actually you talk about pretty much the key points of the paper and they don't change a great deal. For example, in the intervention section, or the control section, even that's even better, you'll be talking about, is this a gold standard intervention that you're comparing your intervention to? For every single randomized control trial, you're going to say that. So actually, everything around that, if you practice enough, you'll just vary your structure. And anything that you can do on the day to take away the stress of the interview, I am a strong proponent for, because you all really want this interviewing job. And the most confident of us were very nervous on the day. So I'd stick, that would be my advice anyway.
I suppose, I mean, to draw an analogy, when you talk through the clinical scenario, that you use an A to E, and the reason you use an A to E is because it's a structure that's universal and people expect. And I think the easiest way of approaching this is create a very similar structure for yourself, so you can't get lost in your presentation, and it's very easy to follow.
Exactly right. Idiot-proof your interview is a good way of approaching it.
And then just someone asked the question, how many points are reasonable for strengths and weaknesses? I don't know how you said about 1. And I think, yeah, again, I'd probably say a couple. If you're getting to 4 or 5 points per bit, again, thinking about how much time you have, you'll run out of time. If you're going to make 5 points about the population, then by the time you get to outcomes, you'll have used all your time up. So keep it simple. Just argue good points that you think are easy to understand and easy to make. And if you've got more, that's fine. They might ask you for some more. But yeah,
I mean, actually, a good point. They need to relatively standardize these interviews. So if, for example, I mean, for all of them, we'd suggest consider an ethical point, for example. But if you don't cover that, be expecting a question to cover that aspect of whatever they're trying to mark.
Yeah. Cool. All right. I feel like that's enough on structure.
Yeah.
Done it to death. So a good place to start, I guess, I think, talked about it last week, that actually a good amount of feedback we had was actually talking through and working through these examples. It was something lots of people found beneficial. Let's start with an example right now. So if you can scan the QR code that you can see on the screen, and we just want to see on Menti submit basically, what do you think what is the population, what is the intervention, what are the controls, and what are the outcomes? And we can talk through those things. And if you have a quick read of the abstract as well. I would say that this is not a particularly, so I picked this abstract. I don't think this is completely out of what you could expect as an abstract to have to present in the academic interview. So it's quite wordy. There's lots of different things going on in it, and lots of acronyms that aren't necessarily defined. So it's quite a lot to get through if you've got to read this through and present it.
And someone's put in here, we cannot see the full QR code.
That's good. Okay, I like. How can we fix that? We can probably fix it live.
I think your face is covering it.
If I do that. Oh no. Hang on. Let's do. No. That's the one. Can people see that?
Someone post in the chat if you can see it now. Lovely, thank you. Yep, that works.
Lovely, we can go back to 2%. And I'll fire up the Augmenti meter. Cool. So I appreciate it take a while. Got no answers just yet. Oh, here we go. Lovely. So they're beginning to come in. Nice. And whilst you're writing out population, intervention, control, and outcomes, if you've got any questions about anything we've said so far, obviously feel free to drop those in the chat.
Yeah, we're getting quite a few on. That's why I'm rapidly.
Excellent.
Yeah, I'm not ignoring you, mate. No worry.
Oh, it's fine. All right. So let me talk through. So I've got a few for the population. So I've got things like preoperative patients at 3 tertiary centres in Australia and New Zealand. I've got 441 adults aged 18 years or older within 6 weeks of a major elective surgery. Got adults within 6 months of elective major abdominal operation. Got patients aged over 18 within 6 weeks of elective major surgery. Intervention, single preoperative physiotherapy. Perioperative adults, yeah. Cool, so most people seem to, I think, have got the population, which is good. What are the outcomes? If someone's not written the outcomes so far, someone put the outcomes out. What do you think the outcomes are? Are there any good questions people are answering on the chat, Jack?
Yeah, you can provide me with these because some of my answers might be a bit rubbish. So one of them was, for the question, tell us about yourself.
Yeah.
Do we answer with our research backgrounds and why we want to do a research SFP, or a more generic answer? I answered that we recommend covering clinical, educational / teaching, academic and personal for the majority of questions. And then there was another question that said, when you say clinical, do you mean career aspirations? So it depends, from my personal view, that depends on the framing of the question. So if it's asking about you as a person, then it might ask, then you may look to frame that as experience today and aspirations. I really think it's up to you how you frame that, but that's how I approached it.
Yeah. So for clinical, I thought I considered clinical to mean kind of the opportunities that would be available in the placements. So I think something that actually we don't talk about is that for all of these SFPs, only one bit of it of the 6 jobs you'll have is in research. The other 5, I would, if you've not ranked your jobs or you're thinking about whatever, you're going to have one research block, but really if you're thinking about what you want to do in the future, whether that be anything from intensive care to neurosurgery or radiology or whatever, you want to think about what opportunities do the other blocks offer you. So for instance, myself, I'm interested in surgery. I've got an academic block next year, but this year I'm doing 6 months of general surgery and including like acute surgery and trauma surgery. And I saw that as a really good opportunity to deal with sick and unwell, deteriorating surgical patients. And maybe some of those will be trauma or neurosurgical patients. So when I was talking about clinical, I talked about what the actual jobs would offer me and what it would be like in the hospital I'd want to go and work in. I think it's easy to fixate on, what's the university going to offer me, but also like you're going to spend most of your time in the hospital, and the people who are interviewing you might even work in the hospital you're applying to work at. So showing that you've done your homework, not just about the research that you're going to be doing, but also where you're going to be working and that that's a good hospital for you for X whatever reasons, I think shows that you've thought about what will actually be the majority of a job, which is working as a doctor clinically in a hospital.
And what about tell us about yourself and the clinical aspect of that? What would you say for that?
So I suppose for me, I was quite lucky. So having done a few things in my life before becoming a medical student, I talked about the fact that I'd worked previously in operating theatres and I'd worked in transplant surgery and I'd seen and worked in neurosurgery overnight and stuff. So for me, I talked about things that had happened pre-med school, but and then I guess I'd also talked about things I'd chosen to do. So like I'd organised an elective in neurosurgery and I'd done the student selected component in neurosurgery. So I guess those things I've also classed under clinical as things I'd picked to do, but were specifically clinical things, not research.
I mean, this structure we're providing is just an idea if you're looking to frame. We're not saying that that's how you have to do it. It's just how our group, how everyone we practice with did approach these questions in order to try and cover off all aspects. And it seemed to, who knows, it seemed to work, but
yeah, I think
small study group and no control group, but it seemed to work.
Yeah, and I think that really you're just trying to come across with a well-rounded answer that shows that you've thought about why you'd be good for something. So if you can come up with a completely different way of doing it, but gets the points that you want across, then there's nothing to stop you from doing that. So just looking through the things people have submitted, I think generally people have got the right idea. So the population, I would say, well, let's just click through. So this is what we thought it was. So we would say the population were adults over 18 years old within 6 weeks of major upper abdominal surgery. The intervention was 30 minutes of preoperative physiotherapy plus the usual preoperative care. The control was leaflet education alone plus usual perioperative care. And the outcome was postoperative pulmonary complications. And some people have actually submitted other more kind of granular descriptions of the outcomes, I guess. The bit underneath this paragraph is probably, so myself and Jack kind of discussed how would we give a summary, and that's probably what we would say. And actually, I would say that's exactly what I would say when asked to give my summary. So that's as much information I'd give about the abstract. I haven't given any specific details of numbers, really, and actually it's a very, very general overview summary of the abstract I've read. I guess
I think any more than that, you begin to eat your 10 minutes of time. And you've got to remember that abstract itself is probably 200 to 300 words long. So your summary certainly shouldn't be more than 50, should it? Yeah. Just thinking logically how we'd approach it.
And also everyone who is, all the examiners or interviewers or whatever you want to call them, will have heard that abstract be presented maybe 50 times in front of you, they will have heard it loads already that day. Unless you're the first person in the first interview on the first morning, they will have heard it. So they'll be bored of hearing it. So get through the summary bit and just clear all of that. And then the bit where you'll stand out and make the most interesting argument and stand yourself out as someone who understands how to present and critique an abstract is the actual critical appraisal bit, not just regurgitating an abstract, which they will already know about.
It is, I'd say that, but with the caveat that it is a skill to be able to read an abstract and take away the key information and summarize that point. And part of this interview is about how you communicate lots of information very succinctly and clearly. So my advice for this bit, again, personal experience, would be that the one thing that I did in my preparation piece of paper was I'd write down, like Dan has done here, like this is the first thing I'm going to say. So these are the exact words that I'm going to say when I approach it, because you'll have time to do so. Especially if you're waiting for 2 hours, then you certainly will have those 2 sentences perfect. So you know, I think there is stuff to be gained there. But like Dan said, that's not the bulk of what you're going to be doing. So don't get stuck down in that.
Yeah, I agree. So that's the summary bit. Let's think about the approach. So then I guess the appraisal, the questions that we would say you should be asking is, why was the study performed? What type of study was performed? Is it primary or secondary data? Was the study design appropriate to the clinical question and the context? Did the study meet the expected standards of ethics and governance? And I suppose kind of joining point 1 and point 4 together, you could ask, was it appropriate for this study to be undertaken? So I think, Jack, as you've previously said to me, we've discussed things where you said there's no defense of, you shouldn't be doing a piece of research if there's already you shouldn't be doing a randomized control trial anyway. There's already a really clear gold standard treatment that's effective. Because actually,
well, no, you shouldn't be doing research that doesn't use that gold standard. Yeah. And I think actually you could almost argue for this paper, which is interesting because you just dragged it off BMJ, didn't you? I think.
Yeah.
That actually the evidence now for prehabilitation, pre-surgery, there's actually quite a good body of evidence. So is it ethical in itself to be putting participants through this study in which there's a control arm that aren't receiving that? Make up your own mind. But this is why we suggest these 4 questions, because immediately they're going to drag you to the key components of the study, and that may well form a primary component of your argument. And my argument for this study, when I was reading it through earlier, was to show there's some interesting findings. But again, being a clinical academic, what does it really add? Well, I mean, we should probably be prehabilitating our patients anyway, so nothing. And also, you know, was it efficacious to undertake it? So that's why we suggest these things.
So if you click actually, you don't even have to do the QR thing again. Your Menti should now automatically update. So let's give you, I'm aware of time, but let's give you, 3 minutes? Let's say 3 minutes. So
see what comes through.
So let's give you 3 minutes to just post whatever you think, what are the strengths and weaknesses of this abstract? Or just any points, any general points you have at all.
I'm going to try it as well.
And let me know if the Menti hasn't updated.
Right, works.
Excellent. Okay, cool. So I've already got a few answers. So someone's put it's an RTC, so that's obviously the gold standard for evaluating an intervention. Participants are randomized, so remove allocation bias. It's statistically significant. Think that the follow-up time is, so there's a weakness, they think the follow-up time is inappropriate, and that potentially it's underpowered. There's no mention of patient demographics or matching. Well, randomization coming up again. Yeah, a good percentage completed the trial. It's a very high completion rate, actually. Relatively large sample size of participants, which is interesting. That one person thinks it's underpowered, one person thinks it's good sample, small sample size, relevant to UK population. Weakness, lack of information why 9 participants did not complete the trial. Yeah, I'd agree. Population was picked appropriately. It's a concealed allocation. Weakness, participants would know, obviously, if they weren't receiving the intervention. So risk of unblinding, yeah. And they mentioned stratification. Is it unethical to not get post-operative physiotherapy? So I would agree it probably is, but I think that's something to just be careful about. It actually, if you look post-operatively, lots of patients receive the same level of care. So they both receive usual post-operative care. The intervention was just that one group would learn some pre-operative physiotherapy beforehand. Patient could do their own physio plan, not proof of no physio. High attrition rate. Okay, so there's loads of stuff. There's loads and loads of things, and you guys are giving really varied answers, which is all really good. The other interesting thing is that they're not all arguing for the same thing. So there is a little bit of conflict amongst the answers people are giving, which is, these are the sort of things that you might be then asked to kind of defend interviews. Oh, you said that. Okay, tell me why. So think about, if you're one of the people who's just written something that I've talked through, then think about if you were asked to defend that, how would you go about defending it?
And I think what I'd add, so most of those points actually were what I wrote down initially when going through this abstract. I suppose the only thing that I'd add is to, again, interpret this study within a clinical context. So not only is it a statistically significant result, but wow, if you can halve post-operative complications, that's hugely clinically significant. And then, again, critiquing the study, if you look at it, it's actually presented as kind of a composite outcome at the end. And you notice that there's no difference in mortality or ICU admission. So again, we really need to look at the data in more detail, because perhaps you're just avoiding the minor post-operative complications, for example.
So myself and Jack went through it, and these are some of the points that we thought we'd made. So again, this is probably potentially more points than you might have time to talk through. But I think when you're doing the appraisal, when you're practicing, putting down as many points as you can think of as you're going through it, and then selecting from those, what do you think are the strongest points? What are the strongest and most easy to make points? If you think of 1 point for population, don't stop there, because then you might be missing, a really key issue that the study has, or key strength, I guess. Fine, let's move on. So the other thing, I guess, just to talk about is also definitions. So in the interview, both myself and Jack were both asked to define things. The things that we were asked to define are in this list, both of them. And we think, as a starting point, you should be able to define every single one of these points. So take a screenshot of it if you want, or you might already have a book of flashcards or whatever. But I think any of these are fair game to be asked what they mean. And now you've seen a list of them, and we've said we think these are all fair game. If you don't revise them and then you get asked one of these in the interview, you're going to kick yourself. And you don't need to necessarily go into the real nitty-gritty detail, but I think not only being able to define things like randomized controlled trials, but knowing a bit about the different types of randomized controlled trials, same as cohort, what's the difference between a prospective and a retrospective cohort, or a nested cohort, and all of those different things. So look at this list, go through it. If you can't define these things in a really clear, simple way, then you might not necessarily know the definition enough now, then that gives you time to practice it, so you don't have to fumble around in an interview for the right words. Anything you'd add, Jack?
No, but I think this can also, again, going back to me nervous, trying to idiot-proof myself. I'm not as smart as you, Dan. So for all of these, I use this to guide my interpretation of each study. So for a randomized controlled trial, or for a case controlled trial, there are a list of strengths and weaknesses for those trials. And you can apply that to any single abstract that you're given and just vary what you say. Similarly, learning the different types of biases, that's not a wasted time, because whenever you're critiquing the abstract, you're looking for evidence that the authors have tried to minimize these biases, and if not, you've got a point there. So I think learn the definitions and think whilst you're learning the definitions, how in an interview am I going to demonstrate that I know this definition, but also that I'm applying it to what's in front of me. And I think I very much imagine a p-value one is a perfect example where everyone will say something that is statistically significant, but actually when you ask people what a true p-value means, they might not be able to define it. And more so, they then interpret that as being clinically significant or something. So actually understanding what it truly means and how you use that within the context of an abstract, I think probably is the difference here between someone that's good and someone that's excellent and likely to get an SFP position.
Yeah, I completely agree. And then I suppose finally, just also knowing that you might be asked to, of things on this list, be asked to describe what the differences are between them. So for instance, like what's the difference between audit and research? And it will help you give an answer to that question, even if you've never practiced it before. If you know what the definition, like if you know how to define audit and know how to define research, it will help you get out of kind of sticky situations for questions you might not have prepared for. So I guess we still have time, and last week Jack very kindly stepped up and performed a live A to E, and so this week it's my go, and we're going to, I guess, talk through or run through a fake mock academic station, so you can get a rough idea of the sort of questions that might be asked, what presenting an abstract and then answering some questions might look like within the 10-minute time limit. So I don't know whether you want to do the timer, Jack, or
I'll time it, mate. We'll do it as if I'll be it.
Fine. Okay, cool.
Okay, so welcome, Daniel, to your
Oh.
SFP interview. You've done very well to get here so far.
Thanks very much.
Please don't be nervous.
Certainly I'm not.
To start with, I'm going to ask you a couple of questions, and then we can get into your interpretation and critique of this abstract, if that's okay.
That's absolutely fine.
Do you have any questions before we start?
No questions at all.
Okay, so I'll start the timer now. So why do you want the SFP that you've applied for?
So in my opinion, so the SFP provides an excellent balance in developing key clinical and academic skills, and forms a foundation of an academic career in which I can go forth and kind of generate and practice evidence-based medicine. So I've applied to this specialized foundation program specifically because of the... Is that all good? You can, fine, sorry. I've been applied to this SFP specifically for a number of clinical, research and educational reasons. So firstly, I aspire to a career in neurosurgery with a mix of kind of placements, including trauma surgery and neurology in a large tertiary centre, providing opportunities to experience working with unwell, deteriorating patients. From a research perspective, I've already discussed kind of research projects with a number of supervisors, and I'd like to take advantage of the vast facilities and world-leading research groups available at King's. And from an educational perspective, the opportunity to teach on the Masters of Neuroscience course would help me develop as an educator and support my application for an Associate Fellow of Higher Educational Academy, and then later working towards a PG dip. And then at a personal level, I live very locally to King's. I know quite a lot about it, and I've visited it before, and I see it as an excellent institution on my doorstep, which I'd love to be a part of. So that's why I've applied for this SFP.
And obviously, it's not easy being an SFP doctor. So what challenges do you foresee if you receive a job?
So I think the two big challenges I see are, first of all, the needing to kind of become clinically competent. So as a junior doctor, it's a big transition point from becoming a medical student into working as a doctor. And given that I'll have 4 less months on the wards, I'll need to kind of learn to juggle that. I think I've already got experience at providing and performing academic work and having academic responsibilities, as well as practicing and training through medical school. So I think I'm already quite good at time management, and I'm already aware this is a challenge, and so I can think about mitigating going forwards. I think the other issue is expectancies of outputs with only 4 months to do a project. So having already spoken to a supervisor and I've got a project agreed in principle that I could start in my first year and aim to work towards completion within my 4-month research project. I think those are the two big challenges I see, but as you can tell, I've already thought about how I'd mitigate those issues.
Great, thank you, Daniel. So do you want to summarise and critique the abstract we've given to you?
Yeah, so the abstract's called Acute Urinary Retention and Risk of Cancer, which is a population-based study based in Denmark. So essentially, this was a study undertaken across all hospitals in Denmark, including patients aged 50 or older with a first hospital admission for urinary retention. This was undertaken between 1995 and 2017 and totaled about 75 to 76,000 patients. And the authors sought to compare the rates of diagnosis for urogynecological and neurological cancers in patients with acute urinary retention and compared this to the general population to look at excess risk. So the author's main finding was that the cancer study, the excess risk was confined really within the first 3 months of follow-up, with the exception of prostate and urinary cancers. I can talk more specifically about the rates if you'd like me to, but actually, and unless you've got any other questions, I'll talk about why I think this is quite a strong paper. So
before you do that, there's a mention of absolute risk here.
Yeah.
Do you mind just telling me what the authors mean by absolute risk?
So absolute risk is essentially the observed or calculated probability of an event in a population related to a specific hazard, and that's irrespective of the time period. So to bring it into this population, the absolute risk is the observed or calculated risk of cancer, which I talked about, relating to the hazard, and the hazard in this population is acute urinary retention.
Okay. And that's fine. Continue with your critique. If that's
I will do. Thank you. So I suppose if we go through this in a PICO format, if we look at the population, this was looking at all hospitals in Denmark. So it's a large volume of people, and it's appropriate age for cancers being investigated. It's unclear whether the Danish health system is comparable to the UK. I'd want to know if it is or if it's not. I'm unfamiliar with the health system. And I want to know if there was any further inclusion or exclusion criteria that's not listed in the abstract. And also, I think it's really useful to know whether the authors looked at this, but how many of these patients were known or undergoing investigations for cancer prior to their presenting with retention. Obviously, I suppose the intervention, the thing they're looking at here, not an intervention brought in, but the kind of hazard or the thing that's brought these patients into the study is acute urinary retention. And I'd also want to know whether they looked at any other forms of symptoms or things that brought them in, or other urinary symptoms, for instance. Kind of looking at the control, it's not clear from the abstract what the baseline population rates of cancer are and how those have been derived. They only give excess figures, which is obviously the absolute risk of the acute urinary cancer patients minus the background. But it would be interesting to see how they've come up with the background and whether this is that rate specific to Denmark, and is that a comparable rate to the UK. And then I go moving forward to the outcome, looking at the cancer diagnosis, which is obviously a meaningful outcome. And I think the follow-up periods were appropriate as well. It's unclear if they also followed up for other things such as like mortality. I think that other general points to kind of be included, I think, are relevant to this study. So this is a nationwide population level data, so it's likely to have been retrospectively reviewed and is therefore secondary level data, not requiring individual consenting. But my key issue with this study, I guess, is that acute urinary retention presents an increased risk of cancer, but if you can flip that around the other way, the cancers they're looking at are the most likely cause of retention. So it's an interesting study, but I'm not sure it really tells us a huge amount more than what we might have expected. And then I guess thinking about how does this paper maybe change my clinical practice, or how does it impact clinical practice? So on a general level, it's a single study. So obviously a cohort study by itself wouldn't change and isn't a high enough quality data in the hierarchy of evidence to change clinical practice. But this may, I'm not particularly familiar with this literature area, but this may add to a growing body of kind of evidence looking at acute urinary retention as a predictor of cancer. It might do, but certainly could be included in a systematic review and meta-analysis.
You agree with the author's conclusions here, Dan?
So just going back and looking at the authors, so I can't see the data. Just having a quick look back at the abstract. So it says acute urinary retention may be a clinical marker for occult cancer, and it should be considered. I think it's interesting because actually, being in clinical settings, if a patient presented with acute urinary retention with an unknown cause, I'd be surprised if that person wasn't investigated for some form or source of cancer. And actually, I think the most likely causes and sources they'd be investigated for are urological and colorectal cancer. So I do agree with their conclusion, but I don't think that that's a particularly helpful or novel takeaway, in my opinion. Do you have any other questions? Yeah.
No, that's fine.
Okay, cool.
Well done, mate. Nice work.
Oh,
let me check if there's any questions about what... No, there's no questions. Do you have any, if anyone has any questions about what Dan just did, pop them in the chat and we'll quickly, I think we've got time.
And so probably, as you can tell from people who just watched that, even though I've had a little bit of time to prepare it beforehand, it's very difficult to talk about everything you want to talk about, to keep a structure. And even though it's just 130 people watching me on the internet, it is nerve-wracking. And so you do need to think about a structure, and structure will hopefully help you going through.
Okay, no questions by the looks of it, so we can crack on. Thanks, Ada.
So I guess final closing things to talk about. So don't give generic, we've not really talked about this, but don't give generic answers to open questions. You need to make your answer stand out. And the way you'll do that is by giving a really, when they ask you about what's motivating you, give a personalized, candid, slick, great sounding answer. Don't just answer it generically. For the abstract, don't focus on regurgitating it. They've already read it. They already know what's coming up. Don't focus on the minutiae and the granular detail. Don't try and perform any complicated mental arithmetic on the fly. Just as you've seen me talking through it, I stayed as far away from numbers. If you're a mathematical whiz, then feel free to dabble in it. But I think you'll find it harder on the day. And if you feel stressed, you'll lose track of where you're up to. And definitely don't underestimate the difficulty of the station. The clinical scenarios are quite intimidating, but I would say of the two, this is the one that's harder to really stand out and excel in. So anything you want to add to that, Jack?
No, I'd agree. Basically, I think the minutiae, tripping up on the statistics is an important one, but I think actually, if you are able to convert things like relative risk into absolute risk and interpret these, I would expect or prepare for questions relating to this, because those are obvious areas that they can really test your understanding. I wouldn't spend huge amounts of time learning different indications and limitations of statistical tests, because that probably won't be covered. But sure, if you want to talk about things like parametric or non-parametric, or some people might have a PhD in statistics, then crack on. But I don't think that's the point of the station. So I wouldn't get too stressed about that. And thinking about how you can now spend your time 2 weeks for some of you before your interview, spending huge amounts of time on that probably isn't beneficial. At this stage, it's more, don't try and learn huge amounts of new information, but really focus on communicating what you already know and interpreting abstracts by just continually doing it over and over, would be my advice.
Mm-hmm. I agree.
We've got a huge number of questions.
We've got loads of questions. So really
we'll go through these after. Yeah, we'll go into it.
We'll answer all the questions after. So really quickly, things that we've used to prepare: How to Read a Paper by Professor Greenall, Professor Trisha Greenall. I really liked it. Jack, you weren't such a big fan. I I think it's probably something that if you've got a few weeks until your interview, it's worth reading. If your interviews are like tomorrow, don't bother. The time has gone for that. Statistical appraisal is pretty good. Something
I loved that. I love that. Actually, in my like breakdown phase of, oh my God, I'm not going to get the job, I don't know what to do, I did spend half a day just going through that, and it actually really focused my thoughts and it was very clear. There's one thing I'd recommend, actually, it would be that book for the academic station. It's just like an introduction to clinical academia that can really allow you to think about how you're going to approach these things.
I would say something that I've never seen people recommend before, but I think they're really pretty good, actually. So BMJ Endgames by Dr. Phil Sedgwick. So they are mostly focused around like the statistics, like number needed to treat and specificity and sensitivity, but they're very simple, short articles. They ask you a question, they ask you to kind of define it or think about it, and then they give you really nice kind of obvious answers and then talk you through the reasoning behind it. So actually, if you're stuck a little bit on statistics or getting your head around some of these concepts, then that might be worth just an evening or something just to run through some of those. And then very handedly, basically any article in any journal, just read them. Read as many as you possibly can and just get used to reading them against the time pressure and critically appraising them.
And I would say as well, we focused on the obvious trials, but it's not unheard of for people to get things like nested trials, case control. So don't just practice randomized controlled trials. I certainly had what did I have? I had a crossover, I think, and it was quite actually difficult to interpret on the day. So do vary up your practice. And also it's not unlikely, so there's a question, where would we go for good abstracts? It's not unlikely that they will just look at some of the larger journals and drag an article off of there. So just go for the common, the common top journals.
Questions? Should I answer some of these questions?
Yeah. Shall I read them out? Let me read them out.
Yeah, all right.
In terms of the personal questions of the project, you said you had agreed on a project pre-interview. Would you recommend contacting supervisors before? Any tips on how to find these? And if not, in London Medical School? Personally, we did. However, not 2 weeks before your interview would be my recommendation, because this can take some time. And it's not a make or break, but it just demonstrates that you've researched the job and you want the job. So you might be able to quickly fire off an email and it might help. If not, don't. I wouldn't lie about it, because I know people would be tempted to, but it's not unlikely you'll be interviewed by someone that works in the department. So if you're going to, make sure you actually have. Next one, would you agree with that, Dan?
Yeah, completely. I think, and I guess, how do you go about doing that? So you go about doing that by, I literally just typed in things like neurosurgery, King's College Hospital, neurosurgery, Imperial, neurosurgery, and then we just trawl through websites and find interesting projects. There's so many things on the internet, and all of these institutes and things are all trying to get grant funding, and so they will have exposure to things on the internet. Most universities have a site map, and there'll be a list of institutes, and you'll be able to see what staff members are key staff members and stuff. But kind of, they will take a while to reply. So if it's tomorrow, then you probably missed the boat.
Yep. Quick question. If you did hypothetically know about the Danish healthcare system and how it compares to the UK, would you make comments about that? Then yeah, you've absolutely won the lottery, haven't you? Yeah, why not? Why not?
I'm actually a real expert on the Danish health medical system, but I just want to be coy and not say anything about it. No, I think definitely, if you know something and you think you can make a good point out of it, then yeah, just say it. Just, the whole point is that you want to make yourself be memorable and stand out, and as someone who's in the know and knows what's going on. So yeah, that would be incredible. But if that paper now comes up, all 140 of you are going to be absolutely, laughing, but it's unlikely.
My thought that triggers from that, it's essentially it's a more formal conversation is all your interview is, with a bit of structure. So, I mean, if you, when talking to an academic, would mention it, then absolutely, why not? Are they using the same abstract for everyone in the day? Don't think so. We had different ones. Not that we shared our abstract, because we wouldn't do that. But no.
Yeah, I don't know. I think they're mostly different.
Yeah.
Is it possible to access the recording? Yep. If you go on this website, the medal website, go on to the event from last week, you can rewatch the recording, and this one will go up afterwards as well. And it's all on the Mind the Bleep YouTube as well. So
brilliant, of course. So we'll go there. Would they ask if you agree with the conclusion without the abstract in front of you? Would you be expected to memorize the general message of the conclusion? I always wrote down the author's conclusion. And also, actually, it's quite a good place to pick at the article, because a lot will make hugely generalizing, sweeping statements based on very fragile methods and data, and it's a line. So yeah, I think it's fair game. It's fair game, to be honest. It sounds harsh, that you might have the abstract in front of you this year, but anything on that abstract is fair game. So yeah, apart from authors' names.
So I did get asked for an opinion about something really specific, and because I was a bit grumpy because I waited 2 hours, I said, I don't understand, I don't know the answer because I haven't seen it in 2 hours. If you tell me the sentence, I'll tell you what I think. So, you know, that worked out okay for me. I'm not saying you should definitely do that, but I think if they're going to ask you for a specific opinion on some numbers, for instance, or something, and you don't have it written down, yeah, ask for it. That no one could criticize you for wanting more information before making a decision.
What do we have access to in the time gap after the prep time? Unfortunately,
nothing.
Whatever's in front of you at the time. Not even a toilet, unfortunately. Did they let you go to the loo?
They didn't say it. So you're just in a waiting room. You're just in like a Microsoft Teams waiting room. So like at one point I snuck out to go for a wee at about 1.5 hours in. And I was like, well, if I'm late to my interview because I'm having a wee, I've had to wait 1.5 hours already. So I'm sure it'll be fine. But yeah, it was literally just a waiting room. I read through my notes. I practiced talking through clinical scenarios and academic kind of talking through the abstract and giving answers, but it was by myself with no one for 2 hours. It was very boring.
Hopefully it was teething problems last year, so hopefully you won't have that. Moving along. Is knowing your project something that will make you look better every time? If you don't know for sure what specialties you're interested, how could you still answer the personal question confidently without being specific about a project? Dan, have you got any advice? I mean, mine would just be just whatever seems right to you. It's not, where you're going to be F1s, you are absolutely not supposed to know where you're going to end up in 15 years' time at the moment. The whole point of the SFP is to just give a flavour of academia. So saying that you're really excited by the opportunity to dip your toe into academia is a good thing, not a bad thing. In my personal opinion, you'll find people that have done PhDs and have worked in academia and know exactly what they want to do. Those people don't necessarily get the jobs. So don't think that it's a disadvantage.
I mean, so just by coincidence, you've met two people who practiced together and both knew really sort of exactly what they wanted to do. But most of or probably approaching half of all the people who are doing SFPs at King's, maybe nearly half don't know what they want to do necessarily. So it obviously doesn't disadvantage you because it's half of the people who have the jobs. I think, how do you think about answering the question? So if you're not massively passionate about any one specific area, then it sounds like you're open to trying lots of different things, but probably the key theme is you're interested in academia and research. So that's how I would tell myself, is that I haven't picked exactly what I want to do, but I know I'm interested in academia. So once I've found whatever I want to do, then that's where I'll go in, and that's where I'll practice those things. And actually, as Jack said, no one really knows exactly what they want to do. So really, all you're doing in an SFP is learning the foundations of kind of clinical research skills and gaining experience.
James said, will you have abstracts in front of you during the 10-minute interview itself? We didn't, but from above, it looks like there might have been a change in the PDF. So as always, whatever we've said, check against the SFP PDF thing that you're given every year. Our experience was we didn't have it.
Yeah.
We just had our notes. We have access to clinical scenario, again, the clinical interview. I don't think I did.
I actually can't remember. I've tried to
It
think.
might have been up there. But I mean, my advice would be anyway, 10 minutes when you continuously practice, this is a really short period of time, looking down and reading anything apart from highlighted words just is going to really throw you off. So I'd go practice without and a few times with, and if you have it, then that's just a bonus.
Yeah.
Don't make assumptions that it's going to be there.
And then, are we able to access our phones or devices? Are we being watched? I didn't know whether I was being watched. I'm not sure whether you know. We're not attached I would assume you will be, and I would not get your phone out. And there's no point risking, someone potentially saying that you've cheated or you've done something untoward. Just put all that stuff aside and just focus on the interview.
Yeah, don't have it in it. If you get an SFB job, not in your choice, especially, is it worth accepting it? Will you be able to change the topic particularly? This is more one for LAK, SS, or wherever you're applying for, to be honest. And we can give our opinion, but it doesn't matter. Is it better to rank preferences according to those hospitals which are neurosurgical units? That's up to you, Dan. Personally, for me, I ranked everything in the order that I wanted it, and I didn't rank anything that I wouldn't accept otherwise. And that was my approach. But that's personal opinion.
No, I completely agree. I think you shouldn't rank jobs that you wouldn't want to take, because if you say no to that job, that takes you out of the kind of process. I think I also wouldn't rank jobs at a hospital doing something you don't want on the off chance you could transfer into something like neurosurgery. So 2 reasons for that. One, it's going to be, if you get, for instance, I don't know, pick a specialty, hematology, it's not going to sound great to your hematological clinical academic supervisor, or whatever the name is, if on day 1 you turn up and say, the thing you do for a job, not interested in at all, want to go do neurosurgery. And then the other thing to think about is, from the neurosurgery side, they will already have people who are doing research, who are doing an SFP. They may not have space, they may not have the resources to kind of accommodate you, even if they wanted to, which they probably would, but it just is about balancing things and making it fair for everyone. So I would say just pick the jobs that you want, and there's more than enough neuroscience, for instance, jobs in London to be able to rank and apply for. I'd
caveat somewhat to say that you should know your program, because we're aware of certain programs. For example, the George's General Practice program, which is notorious for having supervisors that are actually very flexible in what you do your research in. And actually that they see that as a benefit of the program. So don't focus specifically on the title per se, but it still sticks that if you don't want to do the job, then don't put that.
If you are, you probably have all submitted your rankings now, I think.
Yeah, they would. Yeah.
So that's a really good AFP if you've applied for it.
Yeah, it's brilliant. Okay, I
think we should probably draw it to a close. Thanks.
Don't go anywhere. We need to tell them about stuff.
Oh yeah. Don't go anywhere. So hang on.
Don't go anywhere.
Stay exactly where you are. It's all falling apart. Okay, so I suppose the thing to say, so we've had so many signups, like probably over 100 signups at this point. So we've recruited some more AFPs and academic clinical lecturers and clinicians to help out. So we will be in touch with you. If you've not missed an email, it's not arrived or whatever, it will be on the way. If you haven't signed up, tonight is your last chance to sign up at that link there that isn't interactive. You're just gonna have to type it in. And we will get back to everyone with allocations and stuff in probably by
the end of the week.
By the end
of the week.
Yeah. So that's like your final warning, I guess. And then the other thing to say is feedback. Please, honestly, please do fill it out. We're obviously doing this for free. I think 130 people came last time and about 20 people filled out feedback. So it will take you 5 minutes. It's really useful for us. So we have some evidence that we actually did give some information to, a whole group of people, about 140 people this evening. So it's really beneficial for us and helpful for us. And it also means that if we run this again, we'll know how to improve it and make it better for next year. But that's it from me. Anything else you want to add, Jack?
Don't just please do some feedback for us. It's the one thing that we'll get to evidence. And also you guys might be able to deliver this talk next year, and we could turn it into some kind of, publication of how we can widen access for SFP, and stick the middle finger up to all the companies that are charging us or charging students for this, basically. So you are the evidence, so please do that. So we'll leave it up there for a couple of minutes.
Cool, right. That's it. We probably have to jump off soon because the Zoom will close automatically. But if you have any other questions, please do drop them in the chat right now. We'll endeavour to.
SFP link.
Can we see the link for the mock interviews again? Yes. So https://mindthebloop.com//
I quickly copied that. Wait, I'll put it up. Let me find it.
Fine. Jackson, post it. Clinical questions possible during the clinical sessions. Yeah, expect them to ask you questions. I would practice both talking all the way through without any prompts, and I'd also practice asking questions and being interrupted. And yeah, Janice, you complete people. So it really actually massively differs. So Jack, by the sounds of it, was interrupted quite a bit. There were whole sections of mine where I was just talking, just monologuing, and I wasn't being asked questions. So there is clear difference in interviewer variance, which we know is the case because everyone here has sat an OSCE before. We all know that OSCE examiners all react differently, and this is essentially a bit more like an interview than an OSCE, but the clinical bit's basically a bit like an OSCE. Cool. Right. I think we'll stop there. I'll stop the recording. Thanks very much, and best of luck in your preparation. Cheers.
I'll leave and then we'll back in again.
Oh no.